Good evening, good evening, good evening. As you've heard, for those who joined the call somewhat early, or some people would say on time, this is a webinar entitled Demystifying the Science Behind COVID-19 Vaccinations. It is hosted by the Office of Minority Health and Equity, and we should have our presentation sharing very soon. Thank you so much. Thank you so much. Well, as I said, good evening and welcome. My name is Tina Dorch and I manage the Nevada Office of Minority Health and Equity, or NOMI. It's a program that's organized within the state's Department of Health and Human Services and is strategically placed within the director's office. NOMI's primary mission, well, it can be summed up in about 4 parts. And the first is to embed equitable principles in order to reverse health disparities. Second, it's to facilitate the equitable and culturally sensitive provision of quality health care for members of vulnerable populations. Third, it's to acknowledge and action health-related concerns of vulnerable populations. And then lastly, it's to disseminate information and to foster platforms that allow the community, health providers, equity advocates, state agencies, and elected officials to partner and to dialogue. And it's this 4th part that brings us together tonight. As your host and on behalf of NOMI, please allow me to welcome each speaker and each guest who made it their mission to be here tonight. Given how busy our lives are, we don't take that lightly. And we thank you for contributing your unique expertise and perspective to this conversation. I'd like to take one moment, though, and to really specifically thank Nevada's faith community. The pandemic has truly strengthened our working relationship with its leaders. Many not only minister to active congregations, but they support the community at large. For example, during tonight's panel, you're going to hear from Bishop Ron Thomas. He also serves as chair of the Nevada Faith and Health Coalition. And for those of you that are able to join us tonight through Facebook Live, well, we have Pastor Karen Anderson, one of NOMI's 9 advisory committee members, to thank for that. These leaders have brokered outcomes that NOMI would otherwise not have achieved. And now, if you will afford me another luxury, I'd like to make sure that we have everybody in the right place and to go through a little bit of our webinar housekeeping. So for all you attendees who are here, and it looks like we are almost at 100 people, so we thank you for being here. Well, we're going to ask you to stay on mute. But even though you won't be able to engage us by speaking, we still want to know who's here. So if you don't mind, just take a moment and enter your name and any affiliations you want us to recognize. And if you'd like to receive any follow-up materials, make sure that you include your email and put all that information in the chat box. We also hope that you have questions, because this is a dialogue, and that means it's interactive. And so the way we can capture your questions is by you dropping those in the Q&A box. And then lastly, we will be recording this webinar so that for persons who are preferring or perhaps even requiring a version that provides closed captionings, we will have that available as well as a transcript. So again, that's why having a way to contact you is so very important, and you drop that information in the chat box. Now, the last thing I want to do before I turn this over is to just talk about the context and what brought us here today. Well, today is the second of a 2-part webinar series that's been hosted by NOMI to address the role of vaccines during a health crisis. Our flu webinar took place on November 20th, and it's available for viewing on YouTube, and also we can share that with you if you let us know you're interested. But one of NOMI's special initiatives is the diversification of clinical trials. So it made practical sense that we'd expand our efforts to increase awareness about the topics of vaccines. And that brings us to tonight's discussion on the COVID vaccine specifically, or the multiple COVID vaccines specifically. Furthermore, the series has been necessitated by a phenomenon that has been long experienced by diverse communities, but noticeably elevated most recently. And I refer to that phenomenon as something known as the Bypoc Paradox. In essence, BIPOC communities, or those who identify as Black, Indigenous, or as people of color, they're experiencing the most disproportionately severe health challenges while holding the highest degree of understandable vaccine hesitancy. And it's our goal as an office to help bridge that gap, to overcome that paradox. So it's the goal of today's webinar to inform, to empower, and to motivate that BIPOC community so that they can make choices about flu vaccination with confidence. The goal supports NOMI's equity-driven overarching mission, and that is to ensure that the most vulnerable and/or underserved among us achieve and maintain good health. To kick off this event, we'd like to know the consensus of our guests, and we will do so by conducting a simple pre and a simple post-event poll. So, Alex, if you would help me by pulling up poll question number 1. Once you see the questions, it's a pretty simple process. Just answering the following question: from what source would you most trust vaccine-related information? And we ask that you just pick one. Pick the box and then hit submit. We'll give you a little bit of time to do that. And while we're waiting for the tabulations to come forward, you're going to hear this conversation tonight talk about some of these issues and some of these sources and why and how we can achieve a sense of comfort and confidence when making decisions about COVID vaccinations. Tonight's conversation is going to again range from professionals on the medical field and professionals who have conversations with our everyday individual, from those sitting in church pews to those visiting healthcare providers and trusted resources. So I think that you're going to have a very good tabulation of information once we get those comments. And here, I think you can see the results, if I'm not mistaken. And for the most part, this is actually very interesting. We have 100 people with us here on the Zoom call, and I'm not sure how many individuals are joining us just yet by Facebook Live. We'll have that number soon. But of those individuals, 62% say that they're actually looking for information and refer to their local and state health systems as their most trusted source. That's very encouraging, given that I work for one of those institutions. I'm very happy to hear that. And then a very distant second would be personal physicians. Well, we have a physician who's going to be part of our conversation tonight, and I'm certain that once she explains her role in this particular pandemic, we'll see that number tick up as well. So next, I'd like to bring your attention to the next portion of our presentation. And to ensure the most meaningful experience possible, we've decided to proceed with the assistance of a moderator, and not just any moderator. This person is affiliated with an organization recognized for its impact on diversifying the medical workforce. It was founded during a time when the American Medical Association was not very inclusive. And it is my pleasure to turn the reins of this event over to our capable moderator, Ms. Paulina Awua, who will tell you more about the Student National Medical Association and then go on to introduce our first speaker. Paulina?
Hello, thank you so much for that, Tina. So again, my name is Paulina Awua, and I'm a second-year medical student at Touro University of Nevada, College of Osteopathic Medicine, and the chapter president for our SNMA chapter. So the Student National Medical Association is an organization committed to supporting current and future underrepresented minority medical students and addressing the needs of underserved communities. Our chapter has been able to do great work in the community, such as community outreach, pipeline programs, and much more. That is why I'm very thankful for the opportunity for our SNMA chapter to help with this webinar. And today I have the pleasure of being the moderator for the program and introducing our keynote speaker, Dr. Dominic Mack. Dr. Mack is a professor of family medicine at Morehouse School of Medicine and serves as the director of the National Center for Primary Care. Dr. Mack leads NCPC's promotions of health equity and population health through the development of strategies to further research, innovations, and trainings that advance primary care systems. He's the principal investigator and director of the National COVID-19 Resiliency Network and an officer of the Minority Health Cooperative Agreement with Morehouse School of Medicine. He has practiced in Georgia for many years and has served in various leadership roles within nonprofit and for-profit organizations. Dr. Mack strives to develop national partnerships in rural and urban communities to implement equitable and sustainable community-based interventions for better health outcomes for all people. So with no further delay, we will hear from Dr. Dominic Mack.
Thank you, Paulina. Hello, everyone. First of all, I just want to say, you're looking at a man who's had his vaccination. I had a little arm soreness, but it's gone. And you know what? I feel protected. I feel more protected. I'm still wearing my protective gear, but I feel more protected. So today, I just want to say that we're going to talk about vaccinations. I just want to set the tone for our expert panelists and talk about vaccine hesitancy in our community, kind of the origin of it from a high level. Next slide, please. So I'll talk about the effects of pandemics and disasters on under-resourced communities. I'm using under-resourced. We can also use underserved and disproportionately impacted, but I don't know if you saw the executive signing that Biden did. He's using the word underserved again to erase some of the last administration's, I guess they scratched out some of the use of the words like equity, health equity, underserved populations. That word is in use again through his executive order, so we appreciate that. But under-resourced also refers to health systems, primary care practices, rural hospitals, and others that don't have the resources to support us. We'll talk a little about vaccine hesitancy and then the importance of innovative solutions, and I'll tell you a little more about what we're doing. Next slide. So let's talk first about the effects of pandemics. Disaster Preparedness and Equitable Care During Pandemics is a publication in the National Medical Association that we did at Morehouse School of Medicine, specifically within the NCPC. What this article address, this publication and this research address is that disasters don't discriminate against individuals because of their race or ethnic background, but health systems have implicit challenges that do. So what we're saying is it's within the health system of the United States that we have inequitable access among the various populations. In the tempestuous atmosphere of COVID-19, it reminds us of Hurricane Katrina, in which we participated in. You remember Hurricane Katrina, you saw the helicopters, you saw the view of the dome and all those people outside the dome. Well, the same thing is really happening now to multiple populations, multiple underserved communities, but it's just not as visible. Just as in that case, what we didn't do was plan ahead for that community. And you'll hear a little bit about the influenza vaccine outbreak in 1918, but before, during, and after that pandemic and the three pandemics that followed during the 20th century and 21st century, and this one, underserved communities were at higher risk before, during, and after disasters. And primary care falls by the wayside, which means while we're sitting home now, protecting ourselves, and while we're not going to the doctors and the hospitals filled up with acute care, we're not able to get that primary care. So those chronic diseases are festering. So that's another thing we have to look at. But this article is talking about how we need to prepare our communities when there's not a pandemic or disaster for those disasters. Next slide. Let's talk about vaccine hesitancy and some of the origins of it. And we looked at this an article from Dr. Satcher and Dr. Russ at Morehouse School of Medicine talked about triangulating on success. And what it looked at were 9 chronic diseases, infectious diseases that occurred during the 20th century that had a 50% reduction in deaths. And it included influenza and pneumonia. Influenza and pneumonia and these diseases were impacted by 3 things: public health, first though, innovation and research, public health, and then primary care, the medical implementation. So you have to discover things like with the flu, we discovered the vaccine. Public health, of course, disseminated the message and actually helped with the vaccination. But primary care ends up implementing it. We'll look at one more. The other was syphilis. Syphilis was really impacted where we discovered the testing, we discovered things, of course, the medications. There was tracing by public health, and then there was treatment by the health system. But I bring up syphilis because we all know about the Tuskegee experimentation, which we'll probably talk about today. But that is the origin, along with other experimentation and mistrust within the health system, and a reason why we have vaccine hesitancy today. With the flu vaccination, though, I want you to take a look at it and see the success we've had. Look at the other immunization, childhood immunization, polio, measles, how we've been able to overcome barriers and actually almost eradicate some of those diseases. That is proof that it works if we can communicate with communities. So from this slide, I think this would be an overview of what we talk about today. I just want to point out from the last slide, parental attitudes. If I don't take the vaccination and don't believe it should be taken, my child won't take it. If a grandparent doesn't take it, that can affect 3 generations and so on and so forth. So let's not underestimate the impact of parental attitudes and those within the family. But next slide. So I think we'll discuss some of this today. I won't get into much detail, and it's fairly busy. I think these slides will be shared, but I think it's a good overview of what causes the hesitancy. If you look in the middle box, the individual decision, that's me and you. We're either going to make a decision, or the community makes a decision to refuse or accept the vaccination, take it or not, right? If you look to the box to the left, we hear public health, of course, is giving us the messaging. They've developed the vaccination program. We have the logistics, the federal and the state logistics that's trying to get the vaccination delivered. If you look at the box to the right, you have the health professionals. I talked about the medical system, which actually does the implementation or actually gives the vaccination along with public health, but the primary care, the hospitals, et cetera. You see the trust. You need to have trust within the public health system, within the medical system, but the information and the services that they provide impact our decision making. And what helps us to make our decision? Well, number one, it's the knowledge that we get from these entities and the information from others that's shared by people we trust. It's past experiences that we've had within the health system, also with vaccinations, with chronic diseases, other. It's the perceived importance of vaccination, prioritization. We know within our communities that a lot of times, if you have 3 jobs, do you have time to go get a vaccination if you're working almost 22 hours a day? So the importance of how can I prioritize this for my family and for myself? It's the risk, perception, and trust, again, but the risk of the vaccination, you know, the adverse effects that I've heard about. Someone told me they got sick from, I saw somebody, the lady fall out on TV. I don't know if y'all saw that, but when she fell out, I know everyone was cringing because that happened during the first couple of days. But that can impact my perception of risk that's associated with the vaccination. And then there's a subjective norm, just the type of person I am. Am I risk averse? Am I risky? If I'm the first one, am I the first one to jump in line, or do I kind of wait before I, see what's happening before, I do something that's new, innovative. And then, of course, my religion, my faith, my moral convictions. These are things we'll discuss today and how they impact our individual decision-making. And the poll that Tina spoke of earlier is so important because all of those, the questions is wrapped up within this framework. Next slide. So let's just talk about solutions. And we want to, not only the panel tonight, they'll talk to you more about the things that I've kind of just touched on, but they'll also tell you about solutions that are working. We believe it's great. We know some of the issues. We have to research issues and evaluate, but we also have to come up with solutions. The type of implementations, right? How can we improve the care once we find out where those gaps are? And this is what we're doing within the National COVID-19 Resiliency Network, which is a network that has the goal of mitigating the impact of COVID-19 on vulnerable communities, or disproportionately impacted communities, communities of color, but also elderly, those who are disabled, etc. These are our 6 objectives, which can be used for this model, but also within other models. You have to identify and engage who are the communities who are more at risk with COVID-19 and other chronic diseases. You have to nurture and develop the right partnerships, put the community in the face of our programs. We have to develop dissemination platforms to make sure that we have those channels to disseminate information. This information has to be culturally and linguistically appropriate information and tested by the community. We have 10 languages now on our website. We've talked to our partners. We're going to over 30, and that's still not enough. America is truly a melting pot, and there are many languages and dialects that we have to address if we want to reach communities. Then link them to services, and that's including using technology. And in some instances, you can't use technology, but we will use technology with this program where we can. Monitor and evaluate the success, and then share those best practices with federal government, with health systems. But the message that we get from the community as far as how the program, any program is working, should be almost like that PDSA cycle where you feedback and you improve your program while you're doing it. So that's the philosophy behind this one. Next slide. Partnerships. So I want to highlight the importance of partnerships, and we know it. But for this program and a lot of national programs, you have to function at different levels. National partners are okay, but national partners have to have reach into the community, our associations with those communities. So we're looking for national partners. We're working with those who are in every state, territory, and tribe, but those who have reach into communities. And community health workers, our community health advocates, are people who touch the community every day, who are not community health workers, but they sit at tables or they go under those bridges for the homeless, etc. Those are the folks that you need to have in these programs if we are going to convince others and communicate with these populations about the COVID-19. And if you look at the box to the left, it's just our view of partnership capabilities. Each partner should have these qualities: connection to the racial and ethnic groups or other disproportionately populations. They should have some reach and breadth into the community. It could just be local, but can they actually reach their community and communicate with those communities? Boots on the ground efforts. Boots on the ground, of course, is going back to what I said about actually being able to touch those who are in the communities, but existing resources. if a organization, I mean, it's all good, but we need people who can actually support the work and actually use the resources that we're given to give them to actually extend into the community. And the resources are not consumed by their own operation. And that's what we're talking about there. Next slide. This is a sample of the website. When I talk about technology, what the community will be able to do, we would kick this off in February, is actually enter their zip code and see all the services that are in the area. And we want to address the determinants of health, the social determinants of health with this also, which means we know there's been a lot of job loss. You know, people need to know where to get jobs in their area. But first we want to show them where can they get the vaccinations, where can they go for services. And that's focusing on the underinsured and the uninsured population. That's who we're focusing on with this disproportionately impacted communities. Next slide. So to kind of sum up everything, we want to provide a toolkit, and we think programs have to get to the point, or whatever you call them, initiatives, where we provide toolkits for the community. They have to be sustainable, right? We can't just go into communities, do our research or do a program, or once COVID's over, we're out of there. Of course, we depend on a lot of federal funding, and sometimes we have to get the next federal funding. But how do we develop sustainable models with communities? And a lot of times it takes public-private partnerships. Also partner with corporations. They're listening now. We need to get these corporations to partner with us to build these sustainable models that have a business etiquette so that we can sometimes monetize them. And when I say monetize, I mean in a good way. Everything needs money. And that's part of what we have to understand. But these are the pillars: identify, engage the community, develop national partnerships, local partnerships, community partnerships, multimedia, multicultural and linguistically appropriate messaging for communities, link these communities to services, and that model has to be technology and non-technology. I mean, paper-based, right? Monitor, evaluate, and then share best practices among the communities, and have a toolkit that communities can use. And we hope the website, the app that we develop, and the partnerships are sustainable beyond COVID when it comes to pivoting to chronic diseases and other things that affect our community. Next slide. So last, data, I go back and forth, but data will never fully describe a human being. Looking at the electronic health record when the patient comes in the room and never looking at the patient, you know, technology is not going to solve the problem. But if we can locate where a person is, understand their community, their background, their culture, their risk, right? According to what population they're in, we can develop preventative programs for them. We can guide them into prevention that's within their community, and also guide them into the care. So this is kind of like a theme: zip code, community, to culture, to risk, to prevention, to care. Just means you have to understand the community, their culture, and their risk. And then you have to develop your care and your prevention models to be a right fit for those communities. And it's different. There are similarities, but it's different in every community. Next slide. So Alex came right in, right under 20 minutes. So that's it for me, but thank you for having me and look forward to the discussion.
Thank you, Dr. Mack, for laying the foundation and tone for our webinar tonight. So we will now move into our panelist discussion, where we have 4 subject matter specialists who are experts in their field And I ask that as we go through each panelist, you put your questions in the Q&A section, and then at the end, they'll all be addressed. So our first panelist will be Bishop Ronald Thomas. Dr. Thomas is known as a dynamic preacher and teacher, devout student of the word, and visionary. Through his various roles, he has been able to preside over multiple ministries, hold leadership positions in public programs focused on the youth and professional development. Bishop Thomas serves on many committees in the Las Vegas Valley, and today he will highlight concerns and expectations from communities disproportionately impacted by COVID-19. So I would like to hand it over to Bishop Ron Thomas.
First, Pauline, I want to say thank you. I also want to say thank you, Dr. Mack, for that information and that introduction, as well as to you, Tina, and to the Nevada Office of Minority Health Equities for allowing us to share the information. Being a spiritual leader and being responsible for the souls of men, women, boys, and girls, it's imperative that we give people truth. That's my responsibility as a preacher and as a leader, and to teach principles of faith that will cause people to understand, their purpose for being. We're living in a challenging time right now, and people are very concerned about the virus, about the vaccine, and hopefully they're tuning in today, listening to us discuss this, the information that Dr. Mack has given. I just want to make sure that some points are taken away from his information before I even get to the demographics of our research. Number one, we need to be prepared, as he stated. He said, he made a profound statement about family leadership. And if families are hesitant, then their children will be hesitant. And it's the same way with faith leaders. If faith leaders are hesitant, their congregations will be hesitant. You said, Dr. Mack, that we need to trust the knowledge. And that's what why I'm a part of this panel, why I'm a part of the many various coalitions that are in the city, as far as our working relationships to make sure that we give proper information to individuals. You said there are important partnerships that we need to have, and those partnerships need to make sure that we're connected to the community. And I think Tina's doing a great job with being connected to the community, being able to share this platform with us today. So as the chairman of the Nevada Faith and Health Coalition, I just want to share some of the findings from a survey that we've most recently taken between northern and southern part of the state of Nevada, as we try to bring some semblance of knowledge to those that are listening. The demographics on our first slide show you that 94% of the people here are faith or working in some kind of community service related area. So that means these are people that are spiritual, and they're people that are concerned about the community. And our next slide will show you the representation of male to female. In our next slide, it shows you that 26% of these individuals were male, which shows you approximately the demographics, even in the church community, that 1 out of every 4 individuals might be men, 3-to-1 odds of men to women as it pertains to the demographics in our churches. The next slide will show you that concerning our survey, that 21% of those individuals that were surveyed identify themselves as Black or African American. The next slide will share with you now some of the health concerns. In the health concern area, pretty much these people said that they were in good health. 88% of the individuals say they were in good to excellent health as it pertains to their well-being, whether it be mentally, physically, and spiritually. The next slide, they had an opportunity and they were asked to select, of the various things that they were concerned about. And of all their concerns, 3 were ranked high as it pertains to their health concerns. From health insurance, their ability to care for themselves, to high blood pressure issues, to COVID, which was one of the major concerns. And as we deal specifically with COVID, the next slide is going to show you that 82% of those individuals that responded, on our next slide, that shows you that they were extremely concerned about COVID, moderately or extremely. 82% of these individuals of these individuals said they were very concerned about COVID. Who isn't concerned about it? I don't believe that there's anyone that's watching right now that doesn't have a loved one that's been impacted by this, or maybe their family has experienced someone that has died from this virus. So the next slide, the question was asked about the preventive measures that individuals are taking. And as you can see from our presentation, that 80% of these people said they pray. And I believe if it was ever a time to pray, it's a time to pray now. But once again, these individuals stated that they were taking care of their hygiene, washing their hands, or whatever that means to them, but remaining true to the social distancing aspects. And last but not least, 95% of those individuals say they were wearing masks. When we asked those individuals concerning would they take the vaccine, the next slide is going to share with you the concerns. 20% of the people were unsure. 21% of the people said they were really unlikely. So when we start talking about the faith community and those individuals that are representing people of faith, they have all types of reasons why there's hesitancy, as you stated earlier, Dr. Mack. Maybe once again from their parents, and how much influence their parents have on them, the cultural impact. You mentioned the reservations concerning the prior history of the Tuskegee Airmen. So there is some hesitancy with those individuals in the faith community and in our African-American community that are concerned. Our next slide is going to share with you when people were asked a question concerning what services are being provided by those that have been impacted by coronavirus. 78% of the individuals that responded to our survey said they were unaware of any services that are being provided. And so that's where we come in as, this panel discussion where the Office of Minority Health and Equities comes in, where our coalition comes in, and many of you that are on this call, where we come in to make sure that people are aware of the services that are actually in place and the things that will be implemented. The next slide is going to speak more so to the minority aspect of our survey. It says that 58% of the Black individuals that responded to this never got a flu shot. So if they never got a flu shot, what are the chances that they'll take a coronavirus vaccine if they're not exposed to the truth concerning the science behind it, concerning the nature of this particular vaccine? Some have questions whether it's RNA. Will the RNA vaccine impact my DNA? So that's why I hope that tonight's discussion will be able to answer some of those questions that's been provided, by the community. The next slide is going to share with you the Black and Latina, respondents, because now this speaks to the healthcare of individuals. Okay, they're less frequently using doctors for whatever reason, whether it's access to care, whether the respondents that responded are male and macho and have a hard time going to see doctors, whatever the case may be, we see that there's a challenge when it comes to individuals going to doctors. And from the questions that was answered earlier, they're not even asking their physicians, and trusting their physicians, as it pertains to, healthcare. The next slide is going to share with you some of the reasons these individuals said that they did not get the vaccine. And as you can see, they had trust concerns. People don't like needles, was a big hesitancy, but people were concerned about the effects of the vaccines. How is it? Dr. Mack, you said it made your arm a little sore, but you're all right. You look pretty healthy to me. You say you're of sound mind and body, and you feel protected. You feel safe now. And that's what we want from this presentation tonight. We want individuals to feel that they've come away with information that's going to make them feel safe, and hopefully cause them to make a right decision as it pertains to their life, their family, taking a vaccine or not. Our key findings, once again, as takeaways are 43% of the individuals that took this test identified as a minority group. The next slide will show you that 29% of the individuals said that they had an income of over $100,000, okay? But 78% of the individuals, once again, were unaware of any assistance that's necessary. So once again, we have some action steps that we want to be able to make sure that individuals take. We want people to know that the assessment, concerning the apprehensions to taking the virus, we want to clear some of that up. We want to make sure that our message to the community, our congregation, and to our family is very clear. We want to be sure that our faith community becomes a trusted source of information. People look for spiritual guidance. They look for spiritual counseling, and so my desire is that any faith leader that's on this call tonight, that they would come to an accurate understanding of the science behind the vaccine. They would listen to the doctors and those that are in the medical community. They would ask the tough questions when it's time to ask the questions, that all of their reservations, their fears, and their hesitancies might be alleviated so that they can stand as a faith leader, a community leader, and disseminate right information, and then allow those that they serve to make their own conscious decision based on facts and based on truth and not rhetoric. Okay, that's the desire that we have. All right. Once again, you mentioned community health workers. That's another action step. We want to make sure that individuals and that we as faith leaders try to produce as many health or community health workers as we can. So thank you, Paulina, for allowing us to share our findings from our survey. And I look forward to the discussion.
Thank you, Dr. Thomas. And as you said, faith, leadership, and preparations are going to be key elements needed for us to move forward. So now we will learn about clinical trial protocol from our next panelist, Dr. Nicole Stevens. Dr. Stevens conducted preclinical lung toxicology and oncology laboratory research for 20 years. She served as regulatory manager, grant administrator, and scientific writer for the NCI Comprehensive Cancer Center from 2004 until 2015. Since coming to Nevada in 2017, Dr. Stevens works for the State Department of Health and Human Services Division of Public and Behavioral Health as a quality assurance specialist. Dr. Stevens established and serves as the chair for the Society of Clinical Research Associates Southern Nevada chapter, scheduling presentations open to the public, expanding clinical trial understanding for researchers and members of the local community alike. And today she will speak about the difference between various stages and regulations governing a trial, the timeline involved, and safety protocols. So I'll hand it over to Dr. Stevens.
Thank you so much, Paulina. It's really an honor to be here. I do work in Las Vegas now for Optum Care Cancer Center, where we've started up a whole clinical trial operation, and need to get the awareness out about that too. That, as the previous esteemed speakers have mentioned, we all need to join forces to get the word out about science and healthcare and what is available to our community. So with that, the title of this slide is, my focus really here is to discuss the clinical research process in this country, from vaccine and drug development at the laboratory level, which Paulina, you mentioned I used to do myself, through all the many layers of regulatory oversight and conduct by scientists and clinicians across the country. How do we help ensure safety and also availability to all different populations? That is a key aspect of this. So next slide, please. The objectives today in my presentation are to discuss the general new therapy development practices and timelines in the United States, because all of us have heard about, how quickly these vaccines have been developed, which is absolutely true, but there are valid scientific reasons to allay the fears about the speed with which they have been developed, the initial ones, and I will talk about that today. It's a highly regulated industry. The Food and Drug Administration, Health and Human Services have regulations upon regulations. There are many. And those regulations are administrative law. They are not just suggestions about how we need to conduct clinical trial research. It's the law, and the FDA is always watching. For example, I receive emails weekly about citations the FDA has issued, and since last year, a huge majority of those are about fake products claiming to help patients, prevent COVID or treat it. And so the FDA really is sort of a watchdog. Talk a little bit about that. And then the unique concerns within this pandemic and how quickly it has spread across the world. What is the difference between the emergency use authorization by the Food and Drug Administration versus the routine process of approval for a new drug or other therapeutic, all the while maintaining protection for human subjects in the trial. Next slide, please. So why, this has just astounded everyone, with what has happened just in a 12-month period in our country and across the world. The virus is new to humans, and therefore our immune systems have not been sensitized as they have been over many years with different strains of influenza, which causes the flu. So we haven't had a chance to generate immune responses yet to this specific virus. And our antibodies are developed in our body against very specific proteins and other parts of viruses and bacteria. So it was like we were just infants, we're babies. We don't have an immune system that can combat this virus. So this is part of the reason it has spread so quickly and has had such devastating effects. It not only affects the lungs, but other systems, because its method of entry into our bodies is attaching to a protein that exists to a great degree in our nasal cavity, but is also in our blood vessels and our other organs. So if it travels through our system, it can affect those systems as well. Of course, initially, it is affecting people in their lungs. So what does all of this mean for safe vaccine development? Next slide, please. So to dive in a little bit deeper, there's a lot of information on this slide, but I'd like the take-home points to be these two families of viruses. And when we have influenza that was described potentially as far back as Hippocrates in 410 BC, virus actually being discovered in the States in 1933. And these viruses, to create the annual vaccines, which are tailored every year, they're often grown inside fertilized chicken eggs. So they're using some live viruses, growing them, and then they are doing what's called attenuating those viruses so that they themselves will not be infectious when you get your flu shot. But it's parts of the actual virus that are being used to generate those vaccines. The word trivalent refers to being a mixture of 3 virus strains that are given. Quadrivalent is 4. And these are developed based on the viral genetic information from other areas of the world, largely China, the Far East, that are impacted every year earlier than the US. So people have to scramble. They try to come up with the best estimates of which strains will affect us, and then develop the vaccines and issue them, usually, at least starting in Las Vegas, it's a little bit earlier because of all our visitors. So here we start issuing them in August generally. So one note is that the flu vaccines are, for the prior full year season were deemed about 45% effective. And that's just a note I'd like for everyone to please remember as we go on with the talk. The SARS virus family, of which SARS-CoV-2 is a member, the one that causes COVID-19, were first identified later in 1965 with the first one that caused a common cold. And in 2002, we first heard SARS, which stands for Severe Acute Respiratory Syndrome. But that disappeared by 2004 and fewer than 1,000 people died. MERS came later. This was another member of that family that has similar genetic sequences. And it jumped from camels to humans, caused Middle East respiratory syndrome, largely in Saudi Arabia. Only 2 people in the US were diagnosed with it, but they were healthcare workers in Saudi Arabia. Again, fewer than 1,000 people died. Now we're in 2019, and this new strain jumped presumably from bats to infecting humans in China, as we all have heard, daily on the news, and has spread rapidly for some of the reasons that I just mentioned. It's new to us, and there have been very disparate impacts on U.S. communities of color. Next slide, please. So this accelerated discovery, which has reasonably caused some concern for folks, why have they developed them so fast? Why can I trust them? Really, the behind the scenes folks, such as myself, that I used to be behind the lab bench, no one ever hears about you when you're a lab scientist, but it's 5 decades of research now on the related viruses, SARS and MERS, combined with our modern technologies that we did not have in the 60s and 70s and even 80s. The genetic sequencing that is so rapid these days, and supercomputers that have done modeling have allowed for development of the mRNA vaccine by Moderna, with scientists working around the clock, day and night, to rapidly address this pandemic for diagnostics, therapeutics, and the vaccines that are now coming out. Additional ones are coming out. So within only 2 weeks of the discovery, researchers determined how that virus enters our cells, as I mentioned, through proteins in our nasal cavity, largely. And then within just 2 months, researchers, because of these new tools and the historical data, or data, depending on how you like to say it, researchers began phase 1, or the initial trials of a treatment called remdesivir for hospitalized patients, as well as the first vaccine in phase 1 trials in the United States, the Moderna mRNA 1273 vaccine. So these were all based on the genetic sequences that were determined in laboratories. Next slide, please. So as other speakers have addressed, there have been some very bad apples in the barrel when it comes to human research. Some of the most notorious are listed here, and Hitler through just conducted just horrible human experiments on prisoners, but it ultimately led to prosecution in the international setting and started this discussion about human rights and research. Then, as others have mentioned, the totally unethical treatment of African Americans in Alabama who were intentionally denied available effective treatment for syphilis for 40 years. Now, this, I myself, I have studied this as part of my training and my work, but I think most people across the country may not be as familiar, other than especially in like white and Asian populations. They don't have that history that maybe has been passed down in families of, you can't trust people because this is what was done for 40 years, and that is totally justifiable. However, how has the US government responded? In 1974, the government established, based on these and some other unethical behaviors and treatment of subjects or patients, established the National Commission for the Protection of Human Subjects. And through several years and with much scrutiny and input, in 1978, the commission submitted its final report called the Belmont Report. All of us certified in clinical trial conduct are trained on this and must adhere to these principles. The ethical principles and guidelines for the protection of human subjects, which advocated three main principles: respect for persons, beneficence, and justice. And on the next slide, I'll describe these in a little bit more detail. Next slide, please. Thank you. So the three main principles are as follows. First is respect for persons. We must treat people as autonomous agents and protect those of diminished autonomy or decision-making capacity. And this includes people who have not been given sufficient information, or those who have other impairments affecting their ability to make decisions, such as, should I take the vaccine? Should I take part in a clinical trial? Consent to participate in any human research, under the FDA is always 100% voluntary, and people can always stop with no repercussions. Beneficence trials, including those for the COVID-19 vaccines, must be designed to minimize the harm or risks, the side effects, and maximize the benefits of participation. Every one of the known risks and potential benefits has got to be clearly described during a process called the consent process, and people are given a written document that also lists everything that we know. And these forms are based on sometimes the background information from researchers, as I mentioned earlier, like laboratory scientists and chemists. Some of the documents that must come before we ever begin a clinical trial can be hundreds and hundreds of pages of data. And someone has to sit and read that at the FDA and decide if it may be safe, and if we are minimizing harm and potentially maximizing benefits. Justice is extremely important, and I've heard of some reports that really are upsetting to me in this regard when it comes to COVID vaccines. We must distribute the risks and benefits equitably. For instance, we can't test these only on, let's say, prisoners or people that don't have the freedom to make their own decisions. They might be coerced in something. And on the other side, we cannot offer the benefits only to those who, as a report on the news mentioned last week, some people are trying to buy their right to get the vaccine when they aren't in the swim lanes or the hierarchies of how these are to be distributed. They want to jump the line. So as far as justice, that's not acceptable. And in research, we have to abide by these three principles at all times. So next slide, please. Thank you. So this is a little bit busy, but to portray the typical new drug or therapeutic approval process in the US. This was taken from the FDA in 2014. The upper part describes the basic research, can take 3 to 4 years on average with hundreds and hundreds of scientists. Then when that information that I just mentioned is provided to the FDA and they assess it, they determine whether or not a phase 1 trial can begin. And now generally the phase 1 trials are conducted in hundreds of subjects. That data is given to the FDA. They have to stop and say, okay, we've completed it. We think it's safe. It may be effective, but the primary focus is safety in phase 1. Then the FDA will say, all right, you're granted the request to go on to phase 2. Those trials with the same agent are then conducted in thousands of patients on average. And again, we move on to phase 3 trials. Now, they're generally conducted in tens of thousands of subjects. They're often international. Their focus is on both safety and the efficacy or effectiveness. and then fine tuning the doses to again ensure the best safety while balancing with the benefits. Once that is approved, FDA can give the approval or not, and then the drug is legally available, but even further trials can be conducted called phase 4 or marketing trials to assess how the agent is affecting, hundreds of thousands or millions of subjects. Average time for all of this, generally, to get one agent through the approval process is almost 10 to 13 years. So how in the world have we been able to get emergency use authorization for these vaccines in such a short time? I've touched on that a little bit, and on the next slide, I'll discuss that a little farther. So what is, this is partly the oversight, adding to the FDA. It's not only the FDA that has the oversight and who's watching the hen house, so to speak, who is overseeing this. We have what are called institutional review boards, or IRBs, and I saw on previous slides, any research has to be, funded research has to be reviewed by these boards. They're expert committees that oversee research and human trials. The boards must include at least one community member, often an ethicist, often faith advisors, depending on the communities. I worked in New Mexico, and the Native American populations have very different cultural attitudes, so we had to include them in the process. So this board is, these boards, I should say, are tasked with weighing that risk-benefit ratio that we discussed in the Belmont report, and other ethical, societal, local medical considerations all must be weighed before they allow the research to begin. Direct contact information is provided to participants through this informed consent process. A phone number is given to them. Anyone who wishes to, who is on a trial, can call that institutional review board, not their doctor or whoever enrolled them in the trial, and ask questions and express concerns. So that's another level of protections, if you will, or resources. And these boards are highly regulated by the FDA and HHS. And next is, I was just going to mention on that previous slide, there's a resource available to patients called clinicaltrials.gov, and everyone can look up trials on that site. So emergency use authorization is not the same as this routine process. It's only allowed during public health emergencies, issued when there are no adequate, approved, and available alternatives. And again, looking at that known potential benefits, they must outweigh the known and potential risks. And this is how the 2 vaccines that already have emergency use authorization through the FDA have been made available, and the vaccines are being distributed. Next slide, please. A little bit of data on the Pfizer and Moderna vaccine clinical trials. And if you'll note, they were done in tens of thousands of participants, not in hundreds, not in just a 1,000 or 2. So a broader population gives us a better chance of determining whether or not it's safe for all. These vaccines, if you recall the 45% effectiveness of the influenza vaccine, these vaccines are astoundingly effective according to the data. And you can see the top 3 side effects for both are very similar, identical almost to the influenza vaccines. Next slide, please. So as of today, over 406,000 Americans have died of COVID, with approaching 500,000. By comparison, influenza deaths, there are a lot of misinformation out there. It is far worse than the flu. Here's some data to demonstrate that. And there are also many side effects, as I mentioned, related to the other organs in the vascular system that can be effective, and we're only beginning to learn about that. So the hesitancy to accept this vaccine due to the historical violations of human rights that did occur, and unregulated experimentation, as seen in some of the previous data, minority populations have been disproportionately affected. So we need to determine how we can best help every population in this regard and beat this pandemic. Next slide, please. We've talked about some of those other data. So just one example that I found in addition to the presentations we've just heard, I found an NIH-funded researcher who's approaching this with trusted messengers, people with existing relationships in the communities, including faith-based communities, sharing facts in person at clinics and medical offices, which the majority on the poll earlier indicated people are trusting those sources more so than the federal government. There are many fact sheets and information on the internet. I won't say social media per se, but please talk with your healthcare and social support providers as well as your faith-based communities to make that independent, autonomous decision for yourself regarding the vaccines. And with that, I'd just like on the next slide to say thank you to everyone. Thank you for having me, and stay well.
Thank you so much, Dr. Stevens. And I agree. I believe transparency in regulations and development will continue to decrease vaccine hesitancy. So our next panelist is Dr. Curry Winchell. She's a board certified family medicine physician, in addition to being a practicing physician. Dr. Curry Winchell is the medical director of St. Mary's Urgent Care Clinics. With a passion and dedication to caring for and improving her community, she received the 2020 PBS Reno Spotlight Extraordinary Neighbor Award, as well as has several awards and several local TV appearances. And today she will address why it's important to have a relationship with your primary care physician, addressing the importance of vaccine scheduling, the impact of vaccinations on our immune system, and susceptibility to other chronic diseases such as COVID. She will also highlight the distrust among BIPOC populations regarding vaccinations. And now we will hear from Dr. Curry Winchell.
Thank you for having me. I am honored to be amongst such a robust panel, and I'm looking forward to discussing the role of primary care, and then as well as the aftermath dialogue where we can really answer all the questions of the participants that are on this webinar. So my goal is to talk about primary care physician. And so a primary care provider, I like to encompass all different types of healthcare workers, can really help you stay healthy by identifying the diseases you may be at risk for based on your age, gender, and family history. Your primary care provider can provide a physical exam, order pertinent blood work, and discuss and order health screenings that may prevent or identify a disease from occurring. Next, I'd like to talk about availability. So now, I mean, traditionally, we would always kind of think that we had to have a traditional office visit, meaning you make an appointment, take time off work, and then prepare to sit in a waiting room and then wait to meet your doctor. Now, especially with the pandemic, there are so many more options available to patients. So you could, decide to go ahead and go forward with that traditional visit, but there's also other options available, such as telehealth, also called virtual care visits, as well as a lot of people are now resurrecting the traditional home visits. And I think that is an amazing option for several patients. So when we talk about these different types of options available, it's really important that you make the best decision that fits for your family. Benefits of a primary care doctor. First, having that primary care provider can ensure you are up to date on your healthcare screening. They monitor chronic diseases and work to help you maintain a healthy lifestyle. I encourage all my patients, family members, neighbors, and so forth to invest in choosing the right provider for you. It really is a relationship, and it needs to be someone that you feel is hearing your concerns, because overall, you are the best advocate for your health. And so I really encourage people to invest and take the time to find that right fit. Next, we're going to talk about how being vaccinated can really impact the immune system. Dr. Stevens did an amazing job of the overview, and I was just going to give a little bit more information about it. So vaccines, they help your immune system fight infections faster and more effectively. When you get a vaccine, it sparks your immune response, helping your body fight off and remember a germ so it can attack if that germ ever invades again. Now, when we talk about vaccines, we always need to recognize, as the remaining panelists have discussed, there is a significant disparity with vaccinations and people of color. This disparity exists due to several reasons, including past and current mistrust in the public health system. So that's why I really encourage, as I mentioned earlier, that, ask questions about the vaccines that are available currently, not just for preventative health, but also about COVID-19. It's important to educate yourself so you can make an informed decision for yourself as well as your family. Benefits of vaccines. As Dr. Stevens mentioned, protection. We know people of color are disproportionately affected by COVID-19. And when you talk about that, it's important to kind of digest what that means. So if we are disproportionately affected by COVID-19, we know there is an increased risk of catching the disease, which in turn leads to a higher risk of complications. And those complications, unfortunately, can lead to death. And so that is something to really remember when you consider, should I get this vaccine? And when you really look at all of those factors that could ultimately lead to death, I hope after you ask those questions to your provider, read about the vaccine, that you're able to come to the decision and feel that the benefit outweighs the risk. So my next slide, I love this picture. This is something that I feel as a physician, I try to pass along to my patients. And so it is very important to find a primary care provider that is a champion. And I want to repeat that again. You need someone that is a champion for your mind, body, and well-being. And that will help not only yourself, but also others. Live a beautiful life and really be able to make an informed decision. Thank you.
Thank you so much, Dr. Curry-Winchell. Now that we have a general understanding on topics such as community involvement, clinical trial protocols, and how beneficial our relationship with our primary care physician can be, we will move into our last panelist, Nevada Immunization Program Officer, Carissa Lauper. We'll focus on very important topic of vaccine distribution. Carissa has worked for the Nevada Division of Public and Behavioral Health since 2011 and is currently the Deputy Bureau Chief of the Bureau of Child, Family, and Community Wellness. She's considered a subject matter expert on state government administrated immunization programs and served as a member of the Association of Immunization Managers Executive Committee. As Deputy Bureau Chief, Carissa helps lead programs and innovations for the immunization program, including the COVID-19 vaccine planning and response efforts for Nevada from day one. So with no further ado, Ms. Lauper will review the distribution phases and considerations applied for BIPOC communities.
Thank you so much for including me on this esteemed panel. At the Nevada State Immunization Program, we know how important it is for Nevadans to get accurate information about vaccines from the people and professionals they trust the most. I will review what I think is the most boring part of what we've talked about today, but the vaccine logistics and distribution. Next slide, please. Next slide, please. This is fine. So this is the playbook, sorry. This is a brief agenda of what I'll be talking about. I'll start by reviewing the playbook very quickly, explaining the phased vaccination strategy and the federal guidelines we were using to create that, our allocation methodology for the state of Nevada, the rollout timeline as I know it today, a little bit about how you will be vaccinated, sort of a general idea of how we see that rolling out, and then some key takeaways. Next slide, please. Okay, we recently updated what we are calling our playbook. We took the language from the CDC and we have adopted it. We are in version 3 now. This version includes a lot of new information. This is a very technical document. I understand it is not necessarily digestible for the average Nevadan. It is for professionals who are going to implement their own program. So there's also a briefer document that's about 11 pages that is more broad and goes over the way the essential workforce was developed and the recommendations we were using from the federal government to create our plan overall. We began this planning over the summer, honestly. So there was a lot of work on the front end to get to a place where we submitted an actual written plan to the CDC in October of 2020, a month after they told us we needed to write one. So the goal of the vaccine response is to make sure the COVID-19 vaccines released in Nevada are safe and effective. It's also the goal of the United States response. It's to reduce the spread of COVID-19 as well as death and severe disease, to help keep society and the economy functioning safely, including making sure our hospitals and healthcare workers can stay safe and keep working. And it is to make sure that there is equity in the vaccine distribution process across Nevada. Next slide, please. So I'm sorry, there's so much content on this slide. We used a phased vaccination strategy that started in mid-December. The first vaccines came out the week of December 14th, the Pfizer product did. That next week, the week of the 21st, the Moderna product came out. We began our vaccination implementation with healthcare workers, emergency medical services, so think your paramedics and firefighters, our remaining healthcare workers and staff. So anyone supporting the operations of a healthcare facility should have been offered and are being offered vaccines still as we catch everyone in that setting. We also prioritized our law enforcement and public health workforce. And I'll talk about the criteria we use to choose these folks in a slide or two. At the same time, Nevadans living in long-term care, assisted living, and relatedly defined settings were prioritized at the same time. And this was through a transfer program that the federal government helped set up with CVS and Walgreens, where most every state took doses from our state's allocation and gave them to CVS and Walgreens so that they could schedule with skilled nursing facilities, long-term care facilities, assisted living facilities to physically send strike teams of pharmacists, nurses, administrative and clerical staff to do a vaccine event within those facilities for both their staff and their residents. Following federal recommendations, we adjusted Nevada's playbook to prioritize vaccinating older Nevadans and frontline essential workers at the same time. That is the change, one of the biggest changes of version 3 of our playbook. And we are moving into this group throughout the state now, as you're probably hearing. Now, following these groups, we will move to reaching other essential workers, Nevadans who have underlying health conditions that put them at high risk of severe disease from COVID-19, and Nevadans experiencing homelessness. When supply can outpace demand, which it is not right now, and that is the unfortunate situation for the state of Nevada, is that there is not enough vaccine to meet the demand. But when there is, we can reach all Nevadans who want the vaccine. That is our ultimate plan and goal. A couple of special notes that I think the physicians could speak to more if you have direct questions are that pregnant and breastfeeding women can get the vaccine. It is not a contraindication. However, they should speak to their healthcare provider about their specific situation, their risk factors, and their recommendation for getting the vaccine if they are pregnant or breastfeeding. And then finally, children under the age of 16 are not currently recommended for any of the COVID vaccine products in the United States because those groups were not included in the initial clinical trials. Dr. Stevens may be able to speak to this more, but I think some are including children down to 11 or 12 now. So we may see some different recommendations later this year or in 2022. Next slide, please. So our initially prioritized groups, as I discussed, and this is just a good graphic to show you that in Nevada, we saw it as a tier 1, phase 1. We've moved away from some of that language to support broader distribution and more equitable distribution. But we did start with the healthcare workforce and their support staff, as the nation did, as well as with long-term care facilities and residents and staff. And now we will move into these two concurrent lanes, prioritized lanes, which focus on certain essential workforce occupations, as well as the aged population and those with underlying health conditions and others who are underserved, including Nevadans experiencing homelessness who need special attention in order to ensure that we get the vaccine to those individuals. Next slide, please. This is just a nice infographic that we've been using from the Cybersecurity Infrastructure and Security Agency. They have a lot of security in that name. But they were the ones who helped the nation in the beginning sort of outline all of the essential worker types in every profession that does anything in the United States that actually makes our lights come on or our groceries get to the store, all of those sorts of things that you can think of. So those are the groups that we are looking at in our essential workforce occupations. Next slide, please. And this is just a list. So it's important to remember, I take a lot of time when I try to go through them, so I'm cognizant of that right now. So I just will put them on the slide and say it's important to remember when reviewing these groups that each county in Nevada will move at a slightly different pace through these groups, as well as through their aged population, based on their population size, as well as how many of those people are in that group. Lander County in Nevada has more minors, for example, minors in caves, as opposed to Clark County, for example. So for the most part, the rural counties in Nevada will move through their population at a faster pace, proportionally, than Washoe County or Clark County. Next slide, please. The general population groups will be reached concurrently with those essential workforce groups. So you can see it's somewhat complex, but we are trying to both protect and uplift our economy while also protecting those who have the highest risk of severe disease. In the general population in Nevada, we in late December, the CDC came out with a recommendation that was 75 years and older. They had since adjusted that to the 65 years and older. That has all happened within about a month's period, so it's very difficult for the state to adjust to things that quickly. So we had made a recommendation throughout our state for 70 years and older. Our governor reviewed the data in Nevada and decided 75 was not good enough, wasn't reaching everyone, and wanted to get down to 70. Now that the federal government has recommended 65 years and older, we're reviewing that as well with the task force and medical experts to determine if we can go down that low. Our only constraint in Nevada is our supply of vaccine. And then so you can see the general population and wanted to make clear that that NDOC, or Department of Corrections inmates, this is a congregate high risk setting. And also those in immigration and customs enforcement, we have learned those detainees are the responsibility of the state to determine how to vaccinate them. So we'll be working with those institutions to vaccinate those populations following the age and high risk criteria that we're using in the general population as well, so that there's equity in that distribution as well. Next slide, please. This is the criteria that's been used to develop these groups. This is what we've been looking at really since the summer. The level of exposure that someone has to COVID-19. So you can start to understand why healthcare individuals, really of any level, including dentists, who I understand aren't treating COVID-19 patients, they are still seeing people in their offices. And I'm sure if you go to the dentist, you know how close they are to your face. So, we're prioritizing all healthcare workers who are seeing patients, who cannot control whether those patients are following mitigation standards or not. And that's the same case for many of our public safety officers, firefighters, and police officers. When they go out to do their jobs, they can control what they do, but they cannot control whom they come into contact with and what that person chooses to do in terms of risk aversion or safety measures. So you have the level of exposure. Does that person have unavoidable close contact with someone who may have COVID-19? How long is that contact? Do they have sustained contact with a person who may have COVID-19? Again, healthcare workforce. And the importance of the job or special technical skill. There are some positions in say wastewater management that only one person can do, and you need to ensure that that person is there to do their job. Or you have a job that others in the community depend on for community safety and well-being. So we took that into account. We also took into account the likelihood of increasing community spread. Does your job, just by the nature of it, increase spread within the community or within a closed residential facility? Are you a physician that travels to different hospitals? Are you a nurse who works in different assisted living facilities? So a lot of those considerations, as well as, of course, the mortality rate, the likelihood that the population has an increased likelihood of death. So getting into the general population lanes and the prioritization for the older Nevadans, and then those in other risk settings, homelessness, individuals with disabilities. And the morbidity rate, the increased likelihood of infection. And finally, we looked at immune response. And only because with the COVID-19 vaccines, at the time we were creating these, you didn't really have a lot of information on whether an immune response was going to be different in terms of, a lot of times with the flu vaccine, you'll see in older populations, their response isn't as robust. So they're not as protected. For example, there's a high dose influenza vaccine for older people specifically because they need more to get their body going, their antibodies. Next slide, please. Considerations for distributing a limited supply of vaccine. So throughout the early spring, we expect it will be necessary to prioritize vaccine eligibility among and within the identified essential workforce categories. Age is pretty easy for us to deal with, right? But the occupational categories are a little more complex in terms of how we design and implement those vaccination events, and how we're recommending and guiding Nevada's businesses on truly who is their frontline employee. So I will tell you, I guess, honestly, I have not received my vaccine. We have 4 staff in the Nevada State Immunization Program that are out in the field helping either move vaccine around or helping do events. Those people have been vaccinated because they're in the front line and they are in the community. I mostly sit at home and answer emails and phone calls and plan and make decisions and help lead, but I'm not out in the community doing work. So I'm not prioritized for vaccination while we have a limited supply. We're doing that at the state, and we are recommending and asking all of Nevada's businesses to do that as well. Please don't prioritize your CEO over your clerks who are seeing people and in your building every day. And so our guidance is for people to prioritize employees whose job cannot be done remotely and who cannot socially distance while conducting their job duties. And until the vaccine supply increases, position types that can work remotely are recommended to continue to do so. And we support, of course, following all the mitigation measures that we have seen to date, masking, social distancing, all of that, because until you have really a herd immunity level, which we are not sure what that is yet, until you get many, many, many more people vaccinated around you, we will continue to need those mitigation measures to stay safe as a full society. Next slide, please. So the Office of Minority Health and Equity, as well as many of our disabilities advocate services agencies, reviewed our playbook before version 3 and gave us some recommendations. And there's a whole list of them in the playbook, but I just wanted to call out a few to make sure that this community knows we take the recommendations and suggestions seriously. We want to share clear and accurate information about COVID-19 vaccines and the distribution plan in place, and including messaging for the reminder of that very important second dose for full protection. We want to make sure the information is available in other languages than English. We are working with every partner we can think of to get that done. We don't always have those resources at the state in terms of translation. We will provide, and NSIP stands for the Nevada State Immunization Program. Sorry for the acronym there. We will provide education about the potential risks and benefits of the COVID-19 to enable people to make an informed personal choice. And we will work with public and private vaccinators to make sure vaccine sites are accessible to everyone. And we will work with vaccinating partners, new and old, including any agency, any association. We have never necessarily, outside of flu, had to go this broad in our immunization program. We are usually focused on pediatrics. So this has been a large learning curve for us, getting into the adult population more, adult providers, people who speak to adults, to make sure that we plan appropriately to reach every population in Nevada, even if they can't get to a mass vaccine site. Can we find a clinic in their zip code? Can we get a mobile unit to go out there? So now that we have some more robust federal funding, we're going to be able to, I think, operationalize some innovative ways of reaching populations that we've never been able to do in Nevada because we just did not have the resources. Next slide, please. Okay, some final details is that we work with every county. It is a county-based rollout. And so, like I explained before, all of our 17 counties could be in a different place. Our partner, Immunize Nevada, has a great website that I believe Tina and her team can make sure to share. It has county-based plans on it. So you just go to their main website and it has a big button that says, see your county's plan. And we're working with Immunize Nevada and each of our county emergency managers to keep that updated every week. So who will be vaccinating people? Well, right now, a lot of it is county, the local health authorities, Washoe County Health District, Southern Nevada Health District, and Carson City Health and Human Services. and then every community health nurse office in the rural counties of Nevada. We call them CHNs. They help us throughout the rurals. And then we have local healthcare providers, occupational health groups, nurses, pharmacists, emergency medical services volunteers. They can help us with our large mass vaccine events. And then we have local pharmacy stores coming on board as of this week to help with older Nevadans. However, their vaccine allotment comes from us. So anytime right now, when a pharmacy is getting a vaccine in Nevada, that means those 100 doses came off the top of what I got for the state, and it went to a pharmacy, which means I had less to give to the counties proper. So just some of the distribution aspects that we have to go through every week. When will I be vaccinated? Well, unfortunately, the current federal timeline does not easily allow me to give a projection of when you may specifically be vaccinated, depending on what group you are in. Even if you're 70 years old right now, I can say you're eligible to receive a vaccine today. However, if you are unable to get an appointment and all of the appointments are booked, the vaccine supply, again, is outpacing the demand, which is very hard for most of our healthcare workers and public health workforce, because folks are mad at us and we're sorry, but we wish there was more vaccine. So I can't, it's hard to give projections essentially because of such limited supply. Now, very important is that second doses are needed for these vaccines and that they are not interchangeable. So if you get your Pfizer first dose, you must get a Pfizer second dose. And that is 21 days later. Moderna is 28 days later. A lot of questions will come up about that timing. There's a 4-day grace period for vaccines, which means you can get that vaccine and still have it be counted as a valid dose 4 days before that 21 days or 28 days. There is no maximum interval for giving vaccines. However, these vaccines are new and they were studied very specifically. So we do want to keep to those 21 and 28 days as strictly as we can. However, if it's 29 days or 31 days, you will not need to start the dosing over. So that's very important for everyone to understand. We get a lot of questions about that. What side effects should people expect? Well, there will be soreness and redness at the injection site, most likely. That's the most common response. Your arm will hurt, but you may also experience some fatigue or fever, general malaise, feeling bad, or flu-like symptoms, as we call them. That's expected of really any vaccine. It is to be expected. It is evidence that your body is doing its job, that it's mounting the response it is supposed to. At least the physician on our team has advised us that people shouldn't treat themselves with aspirin before going to get their vaccine dose. Make sure you get that dose, allow your body to have, to do its job. If you're feeling very, very uncomfortable or have a high fever, at that point you can take some Tylenol or a fever reducer. Next slide, please. Okay, my key takeaways are that there's an equitable and science-based plan to distribute the COVID-19 vaccine in Nevada, that there is an existing vaccine distribution infrastructure in the state of Nevada. We did do this, just not to the scale that we're having to do with COVID-19 vaccine. The Nevada State Immunization Program is primarily responsible for administering the Vaccines for Children program across the state of Nevada. That's a program that ensures that underserved children, including those with Medicaid or who are uninsured or who are Native American, can get their childhood vaccines at no cost to them and their families, and also at no cost to the physicians who stock them. So that's what we do. We know how to do this. We know how to order vaccines. We know how to ship them to our providers. We know how to manage storage and handling. We're just doing that at a much larger scale now. The COVID-19 vaccine clinical trial processes, as you heard, will only allow for a safe and effective COVID-19 vaccine to be released for use in the United States, whether through emergency use authorization or final licensing. And the reaction after getting a vaccine is normal, it's expected, and it's going to be different for every person. But vaccine confidence is the key. And if we are transparent and honest with people about what to expect when they get their vaccine, I think they will appreciate that and be more likely to not be so scared if they do happen to have a fever or feel bad after their dose. Thank you.
Thank you, Ms. Lauber, and to all the panelists. And thank you for all allowing me to be the moderator for this webinar. We will now move into our question and answer portion of the webinar, which will be facilitated by Minority Health and Equity Specialist, Alexandra Neal.
Thank you, Paulina. Our first question for any panelists who would like to answer is, in terms of the COVID vaccine and the side effects that come with it, if you experience the side effects, should you be concerned that you are contagious and need to quarantine? Side effects from the vaccine, to be specific.
So I can take that. That's a great question. So we know when you receive the vaccine that you are going to have side effects. I actually like to use a word that one of my colleagues describes as a rehearsal. It's a rehearsal for your body to respond and mount an attack. And so when that happens, and the fact that you just recently received that in vaccination, you can really have peace of mind that it's due to that. Now, if you had, maybe not adhered to social distancing, maybe were in a party or something like that before you received your vaccine, it's definitely possible, that you could have contracted COVID-19 before even that same day that you received the vaccine. So I think it's important to really look at what measures you have really put in place prior to receiving that vaccine and then making an informed decision. You can always reach out to a healthcare worker, a provider to get more information. But I think just thinking about what happened, what preceded that vaccine will be very helpful in your decision making.
Thank you, Dr. Curry-Winchell. Our next question is, I guess, for Carissa or Dr. Well, actually, about 4 of you guys could answer this one. But I'll pose it towards Carissa or Dr. Stevens. What, if any, concerns should someone trying to conceive have with the vaccine versus no vaccination? So they're not pregnant, but they are looking to conceive. Should they have any concerns with taking the COVID-19 vaccine?
I will say I can't answer that question. So that's a clinical question. It's a little beyond my capabilities.
I don't know if that's a question that we have an answer to as of yet, but is there another person, Dr. Stevens, maybe?
I can't answer the question either, but I think that some of the information that's been shared about the 2 vaccines with the emergency use authorization, we might be able to research that and get back to the attendees. Do any of the physicians have comment on that?
Yeah, I have a comment. All the literature I've read, of course, if you are planning to get pregnant, consult with your physician. But what's indicated is that you still take the vaccination and then, just consult with your physician and allow that time, before you try to conceive. But, definitely, if it's not immediately that you're trying to get pregnant, you should have the proper protection, but consult with your physician, take the vaccine, and then of course work with physician on planning toward the pregnancy. Now, if you think you're pregnant, you're trying to conceive, I don't think it's been enough studies done to absolutely say that, okay, you should conceive right after you take the vaccination. That's
And to that point, this is Tina Dorch for the record. To your point, Dr. Mack, there is one physician here in our state who was doing Moderna trials. She's an African-American woman, kind of a unicorn in our state. And we had this conversation, and, you know, as fate would have it, while it was not intended, some individuals did become pregnant while they were included in the trial. But to your point, their numbers who met that profile were not statistically significant. So she would not, even in her role, having performed the actual trials, be in a position to answer it. So I know that these are the type of questions that we want definitive answers to, but I think one of the things you heard as a trend through everyone's remarks is that we're going to be transparent. And right now we don't have a definitive answer, but I think Dr. Stevens gave the best possible answer. This is on everybody's radar screen. We know that life has to go on and people will be having babies. So this is going to be something that I'm certain is studied.
Thank you.
Yes, and I'll just add to that, I have not seen any of the consent documents for these vaccines, but I know in oncology, if there is a concern with the body of knowledge that we have about a particular agent, there are there's a lot of advisement about whether or not one should wait, especially a lot of these are chemotherapy drugs, should not become pregnant while you're on, you know, this agent. And that goes for some of a lot of the approved agents as well, or have to, if you are agreeable to it, to use contraception. Speaks to both males and females. So I don't have the answer about the COVID trials. I think as they expand, I looked on clinicaltrials.gov, they are initiating trials in the adolescent population, or I should say less than 18. And hopefully as more and more data are gathered, you know, people will be able to answer that question and advise based on data. But I'm sorry, I don't know how they approach that in the existing trials.
Thank you, Dr. Mack, Dr. Stevens, Tina, for your answers. And the next question would be directed towards Pastor Ron Thomas about the survey that the Faith in Health Coalition did with UNR. Regarding the survey and its findings, where the participants asked about the influence or role of politics and their hesitation or willingness to get the COVID vaccine?
And the answer to that, to the panelists or to the respondent is no. We didn't take politics into consideration. We wanted all things being equal for an individual to just make an assessment of would they or would they not. And that speaks to the concerns of our community. We have community people that are concerned about politics' role in it. Everything from, is there a money-making thing behind it? Is somebody making money from making the vaccine? So that's the skepticism of our communities. And hopefully, once again, we can address some of those things. But the answer to the survey or that question is no, we didn't take politics into consideration. We wanted all things to be equal. And we only gave them subjects such as allergies, were they allergic, did they have trust concerns? And in our survey, the trust concerns that they had for whatever reasons, political or whatever, was a percentage of that answer. And I believe it was about 15% had trust concerns.
The next question is for Carissa. What vaccination programs / supports are in place for the seniors that are homebound that fit into the now revised category for COVID-19 vaccine distribution?
Thank you for the question, Alex and Vance. So that's a complicated situation, compounded by very fragile vaccines. So the vaccines themselves are difficult to move around. Once you have punctured a vial, they don't like you to transport it at all. So you're not supposed to take it from the place you're vaccinating people to other places. However, we have worked with the CDC one-on-one. So every state has kind of asked them one-on-one, and we're waiting for some final written information. However, we do have clearance to work with strike teams who in a one-way manner would be able to take, say, a vial or 3 of Moderna product through a, say, a senior apartment home or something, or work with disability services to identify a specific area and then go very methodically to those homes and vaccinate those individuals, because you have to be very careful with the storage and handling and the transport while you're doing it. So it is possible and we are working it out, but it is logistically a little complex.
Thank you, Carissa. One last question, and then any following questions that are submitted, we will be writing them, or we will be writing them down. And when the slides and recording is available, so will be the answers for the questions that we may not have gotten to in this time period. For what, I guess this would either go for Dr. Mack, I believe, or Dr. Bio. What, if any, are the concerns with people with autoimmune diseases such as SLE or RA getting the COVID vaccine? So if they have an autoimmune disease like lupus or rheumatoid arthritis, is there a concern for getting that, or is that talking to a physician?
I can speak.
Okay. Of course, to bring your questions regarding the vaccine. I am now going to turn the webinar over to Tina Dortch.
Thank you, Alex. And I can't reiterate that enough. And that's one of the main reasons why we have Dr. Curry Winchell on the line, that you heard a consistent response to questions. Consult with your primary care doctor. And the better they know you, the better care they can give you. And so we can't reinforce that statement enough. We are coming to the final few minutes of this webinar, and we are still holding strong at about 85, almost 90 people. So that is amazing for this late hour. And we want to pivot, as I mentioned earlier, to a post-event poll question. And Alex, if you can go ahead and pull that up. You probably can guess what the question is, but we want to know at this point in time, based on the presentation, how likely are you to take a COVID-19 vaccine? And note that there is a spot at the very top that says, I have already taken the COVID vaccine. So if you could just read through those options, we'll give you a minute or two, and we're very curious to see exactly where at least the folks on this line stand as of today. While we're waiting for that, let's see if I can move that out the way. There is just thanks to be had and thanks to be shared. I know for some of the individuals on this call, it is approaching 11 o'clock at night. And so I so appreciate your time, and to Drs. Mack, Thomas Stevens and Curry Winchell, as well as our ever faithful Ms. Lauper. We thank you for your service and especially the dedication that you're showing during this very difficult time and making this discussion happen. I know, again, we don't take for granted your carving out time to make it happen. So let's see, no response yet, Alex, still doing its thing.
The votes are still coming in.
Okay, well, that's good. Okay, we'll take that. Well, we're going to also end with an opportunity for individuals to engage in a survey. The University of Nevada at Reno School of Medicine, in partnership with the Department of Health and Human Services and Immunize Nevada, is conducting an ongoing survey to learn about the general perceptions and knowledge about vaccines. And we've got a slide that we'll put up after we discuss the poll. So let's look at this. So we're looking at 58% saying that they've already taken the COVID vaccine. I was not expecting that. And then beyond that number, 30% thereabouts said they will take it, and 13% said they may take it. And very few, no one said that they will not. So I can't do simple math. I don't know if that equals out to all of the folks who are on the line, but I think this is a very, very encouraging outcome for this particular survey. I think my panelists would agree. That's very encouraging. And Alex, if you can put that slide up that shows the opportunity that I mentioned. This is a way, just as we leave this place and as we're going to go out and, try and talk to our friends and family, and express to them the importance about the vaccine, and if not taking it, to at least educate yourself so you can make an informed decision. As I mentioned, there's that partnership between the UNR, Reno School of Medicine, Health and Human Services, and Immunize Nevada, and they're going to be releasing reports every month. And many of the statistics that you saw at the beginning of the presentation on that scrolling deck came from their work. So having said that, we're going to wind down, and I want to leave you with a comment, something that just really touched my heart from yesterday. It's an excerpt from The Hill We Climb, which was an inauguration day poem by Amanda Gorman. And she says, as part of that wonderful, wonderful piece of literary work, somehow we've weathered and witnessed a nation that isn't broken, but simply unfinished. And I want that to resonate because all of us are health equity advocates, and together we can beat this virus. So all that's left is to get to work. Having said that, I'm going to bid everyone a good night and thank you for your time. And again, we've got a lot of data that we're going to crunch on our own. We've got lots of people who want data or comments, or the PowerPoint, and we'll be sharing that. And again, unless there's anything left to say, everybody, I think you've done your job and you've done it well. Good night.